second last presenter for today, Dr. Pranav More. Dr. Pranav, well, is from my city in Pune, but he's been trained in KEM Mumbai, AIIMS under Dr. Tityal and Dr. Namrata, and later in Arvind Eye Hospital, Madurai. He's currently working as a cataract and cornea consultant in the Sahyadri Hospital and his own Ayush Eye Clinic. And he also is visiting faculty to 2 medical colleges in Pune and PCMC. So over to you, Dr. Pranav. Unmute yourself and share your screen.
Yes, you're on, Pranav. Just just go to slide share.
Audible?
Barely.
You have to increase your volume.
The audio, please. Admin, please look into the audio.
Is that good now? Is that good now?
No, it's not good. Louder.
Is this okay?
Very good.
Yes.
Okay. Good evening to all. Warm wishes from Pune. I wish to thank AIOS Scientific Committee and Dr. Somshila for having me here. It's a nostalgic feeling because I'm presenting a case after almost 12 years in front of my teachers, Professor Tityal and Professor Namrata. I hope they are a bit milder on me this time as compared to my good old residency days. The topic that I'm going to present is a case presentation on a young lady, 23-year-old lady who was diagnosed to have bilateral keratoconus. The right eye had a heel hydrops, 2 years old heel hydrops with a significant amount of scarring, whereas the only seeing eye which we had was having a moderate keratoconus, and I had offered her a coragen cross-linking procedure for the one. Her best corrected visual acuity in that eye was 636. There was no other predisposing factor, no systemic associations to have keratoconus. She didn't have any atopy. She didn't have any other systemic conditions which could cause secondary keratoconus. The procedure that I opted for was accelerated CXL with an epi-off. The procedure went off pretty well in classical aseptic precautions taken in an OR, and uneventful procedure. The patient did have some pain post-operatively, which is expected in an epi-off procedure. The immediate post-op, the patient only had a BCL in situ and no major complaints on day 1. She was put on a routine protocol of antibiotics and lubricants in the immediate post-operative period. This procedure, which I did, was on a Saturday afternoon. And so there was a Sunday where the patient was seen by my resident and fellow initially. And they just reported back saying that the patient's pain has reduced and the patient is on a routine post-op course. So the patient was sent home on Sunday afternoon. And the patient had no complaints till Monday afternoon when the patient came back on day 2 with significant amount of pain. Ideally, post C3R, if the patient is on a BCL for 48 hours, the pain should settle down and the patient should be much relaxed, even if it's an epi-off procedure with the BCL in situ. But the patient presented on a Monday afternoon around with pain, significant amount of pain now, a lot of redness, quite an inflamed eye, and a lot of whitish lesions, which I'll show in the next slide. So this was the presenting feature on day 2. Quite ghastly to look at in a patient who has just undergone so-called not so invasive, minimally invasive procedure for a refractive condition like a keratoconus. And this is very ghastly. I almost missed my heartbeats there when I saw this in a post C3R patient. And looking at these are nice elevated gelatinous lesions. The central lesion pretty much restricted to the area of epi-off zone, and a very nasty looking lesion to see on day 2 in a post C3R patient. I was really worried. So obviously the epithelium had not healed off. There was an overlying ulcer defect. Scraped the patient, send it for a microbiome assessment. The attending microbiologist in the hospital reported it as gram-positive cocci. And therefore, this patient was started on as a normal empirical protocol without having a culture report. Put this patient on a fortified vancomycin with moxifloxacin eye drop 1 hourly, hoping that this patient will start responding. We did send it for culture and sensitivity also as per the protocols. So I had to wait till the reports came in after 48 hours, which was on day 4. And the day 4, the reports sent to me by the microbiologist suggested that the patient doesn't respond to vancomycin. He doesn't respond to any of the fluoroquinolones. So the primary drug of choices that I put in for such a ghastly situation in a minimally invasive procedure were not going to work for me. So then I went through the report, and it just showed that the aminoglycosides is one of the groups which is working pretty well or has an intermediate sensitivity as compared to the ones which we had chosen, vancomycin or moxifloxacin. By day 6, I think day 5 or day 6, the patient walked into the clinic saying she's not feeling fine. However, we put this patient after day 6 on amikacin 2%, because as per the culture reports, the patient was started on amikacin 2%. As the time passed, we did notice that the patient was responding pretty well, and just taking some anecdotes or taking some inspiration from the SCUT study performed at Arvind Eye Hospital, I decided to introduce a mild surface-acting, low-dose, low-potent steroid in the form of loteprednol, itabonate. And this, I started at a frequency of 3 times a day for the first 3 days, but I did keep this patient on a close follow-up. The epithelial defect had almost healed, but there was a significant amount of scarring and an inflammatory infiltration going on in the cornea, for which I then decided to put this patient on loteprednol on day 14. The response that I actually noticed after introducing loteprednol was quite impressive, and the scarring from the first day 2 image to the day 21 image, it just clearly says that introducing steroids at the right time have helped in a situation, a sticky situation, a nasty situation like this, to salvage to a point there wherein by day 40 I had a scar which was barely minimally visible, not significantly hampering the visual acuity. Uncorrected visual acuity at day 40 was around 636, which along with the scarring, I thought was rather a more reparative and much of a respite for going through a post-operative infectious keratitis in a C3R. So quite a scary situation to start off with, but shouldn't lose faith in managing it, sticking to the protocols, going by the medicine, going by science, playing around with it, altering things as per the reports come up has helped, and making use of scientific research that has been provided to us through so many research trials has actually helped recover this outcome for us in a situation which looked very nasty and ghastly in a nearly one-eyed, I wouldn't say one-eyed, but nearly one-eyed patient, a young woman with just a keratoconus and undergoing a C3R procedure. The thoughts that I had on my mind was epi-off. So there has been an epi-off versus epi-on debate for a long time. Either of it are efficacious in terms of managing progression of keratoconus, but having a look at this kind of a scenario, you generally don't want to see something like this. An epi-off versus epi-on was something on my mind. Should I switch over to an epi-on procedure pattern? Is there a good time to start topical steroids? What would be a good time to start steroids? I usually would start topical steroids on day 3 after the BCL is off. Even if there is a minimal epithelial defect, I would still choose to put a low-dose surface-acting loteprednol kind of a molecule. And has anyone encountered a scenario, because I was going through the literature then, there are only 10 cases published worth considered as post-C3R infectious keratitis. There were 50% of them bacterial, few of them were fungal, and 2 of them were acanthamoeba. 1 or 2 odd were herpetic. Has anyone encountered a ghastly scenario like this of C3R, wherein probably sometimes you might have to, like in acanthamoeba, where you want to do it as early as possible? Anyways, DALC is one of the considered procedures for keratoconus. So I was just wondering if anybody would have thought of doing an LK, early LK, if this was not going to be responding or recalcitrant. Would have thought of doing an LK, early LK, if this was not going to be responding or recalcitrant.
So thanks, Pranav. We'll go to the discussants, Dr. Namrata Sharma.